Okay, hello. Here we go with class number 2 of psychopathology. I apologize if there's any disruption here as I record. I'm using a new computer, so hopefully everything will work smoothly here. Um, it struck me after we met last time that we didn't go so much into how the DSM-5 is used. I know I talked about it, but we didn't talk so much about its use and how it works and all that sort of thing. So I thought that would be a good place to start right now. So, as I said last week, and as I know you're aware, there are several different diagnostic texts out there. By far the most highly used, well respected, well researched one is the DSM 5, Diagnostic and Statistical Manual of Mental Disorders, 5th edition. And the way the DSM 5 works, it is a large text. I know you have a copy of it that lists the criteria for each diagnosis. Um, and in order to give a person a certain diagnosis, they have to meet a certain number of criteria. Each criteria has to have uh, lasted a certain amount of time. And there are different ways of defining disorder, either based on how long the symptoms have lasted, how much they impact on the person's functioning, that sort of thing. So, different diagnoses have different sets of criteria. Many of them are used as a way of establishing what symptoms are present, but they also could establish um, how much they impact on a person and how long that impact lasts. And you will see in the DSM 5 that it, like I said, it is every one of them has a series of diagnostic criteria, and it will have things like how long, they will have things about the duration and the severity. And sometimes it will be multiple choice. Like it will say person needs to have 3 of 6 of these diagnoses. And each one of the categories of psychological disorders that we will discuss during this class: depressive disorder, anxiety disorder, bipolar disorder, schizophrenia, autism spectrum disorder, and PTSD. All of them have their own chapter in the book, in the DSM 5. And so we will be looking at the criteria for each one of them. So the way you would use the DSM 5 is you would meet with the person, you would do a diagnostic interview. Diagnostic interview involves asking the persons a series of questions, clinical interview, where you would delve not only into asking questions about their background, but you would also gauge how the person appears to you. So you would look for things like, do they appear depressed? Do they appear anxious? Do they seem worried? Are they having difficulty staying focused? Do their uh, responses make sense? Are they being tangential? Tangential means they just sort of ramble. Are they being perseverative, meaning they seem to bring up the same topic over and over again for no apparent reason? Are they giving relevant responses to the questions you asked? That would be a clinical interview. And in the clinical interview, when you write a report, you would usually write it as the results of a clinical interview would usually come out under a section called mental status examination. Uh, and when you write up a mental status examination, you would have things like appearance. Is the person cooperative? Are they, how is their attitude about being examined? Are they dressed appropriately? Does their hygiene seem clean and appropriate? Are they giving sufficient content to answering the questions that you asked? If they are not, and you have to ask follow-up questions, are they responding to the follow-up questions? What does their mood look like, sound like? What is their affect? I'll describe the difference between mood and affect in a minute. Do they have suicidal thoughts or plans? Do they have homicidal thoughts or plans? Do they show any evidence of psychotic symptoms? Do they show flight of ideas, loose associations, tangential thinking, perseveration? Are they showing evidence of delusional thinking? Are they talking about people being against them? Are they talking about having some sort of special understanding of their situation or special understanding of the problems they're addressing? Are they um, are they seeming to be impacted by internal stimuli that you can't see? Do they seem to be responding to sounds that aren't there or people who aren't actually there? Are they oriented to time, place, and person? Do they know what year it is, where they are, and who they are, and what sort of situation they are in? Do they seem to know who you are? Um, are do they have intact recall for short-term and long-term material? Um, do they seem to be receptive to any suggestions you make about treatment, or do they seem receptive to whatever treatment they have been receiving? Do they seem receptive to the idea of treatment at all, if that's being discussed? What is their attention like? Are they able to remain focused and concentrate throughout the interview? Are they easily distracted? Those are some of the main points that would be in a clinical interview and that you would then include in what is called a mental status examination. Now, the reason all that is relevant is because the material that you will gain from the clinical interview and from the mental status examination makes up a lot of the information that you will use as a way of determining what diagnostic criteria this person meets, not only from the mental status examination, but also from any history that you have about the person. Now, the history may come only from the patient. The person you're evaluating may be the only person who gives you any information about their history. When you are evaluating someone, you also will often try to get additional uh, material about their background, old clinical records, records from school, records from employers that they may provide you, but you don't always have that. So, very often when you come up with a diagnosis, it will be through a combination of history that you get from the person, possibly from records, sometimes from their family members, if they are a minor, under 18, or if they are willing to let you talk to their family members. Keep in mind, people could just say, no, I don't want you to talk to any of my family members. Um, so history will be part of it. And then the other part of it will be material that you get from a clinical interview. And the clinical interview will make up this mental status examination. What you may also use, but not always, is some sort of psychological testing. It may be shorter tests, like, say, the Beck Depression Inventory or the Geriatric Depression Scale for older adults. Those are two, or the Hamilton Depression Inventory. Those are three relatively short psychological tests that are very focused. They are only meant to measure depression. Or you may use longer instruments. Um, the MMPI-2, the Minnesota Multiphasic Personality Inventory, now with its second edition. That is 450 plus true or false questions that the person answers about their own personality. Um, the Rorschach, which is the famous ink blot test. Those are two examples of longer psychological tests. Um, the difference between them, other than length, is because of its length, those latter two um, sort of cover a whole lot of ground. There's a lot of different diagnostic possibilities that they could measure. The shorter ones tend to be focused only on one area, depression. There is a Beck Depression Inventory. There is also something called the Beck Anxiety Inventory. Um, and those are tend to be focused only on one area. There are pain scales where the person would answer questions about their level of pain. Usually the shorter ones are focused only on one area. And then there's a whole other category of psychological tests called cognitive tests. Those are ones that are not meant to test for psychological disorders, but test more different areas of cognitive functioning, attention, memory, executive functioning, those sorts of things. So when you are doing a diagnostic examination, a psychological examination, you usually will get that material from two areas and possibly three areas: history, mental status examination slash clinical interview, and psychological tests. I say mental status examination slash clinical interview. The clinical interview is usually also where you will get the person's history. Um, and so what you will be doing is asking about their history while at the same time examining how they're answering the questions. So clinical interviews usually have dual roles. You are gathering information, but you are also having the chance to examine the person and see how they're responding and see how they're dealing with things. That information, all of that information, you would then use to come up with a diagnosis. And the diagnosis would be from the DSM 5, and you would use the information that you obtain from the clinical interview to determine what diagnostic classification the person fits. You would use that information to determine where the person fits in the DSM 5. Okay, so you would then go to the text and come up with a sense of, does this person seem to have problems with depression? Do they seem to have problems with anxiety? Do they seem to have fluctuation between animated and depressed? Do they seem to have hallucinations or delusions? All that sort of thing. So from there, you would um, kind of have a place to start as far as your diagnostic picture. You know, if the person seems more depressed, then you would turn to the depression disorder categories. If they seem more anxious, you would turn to the anxiety disorder. And then from there, you would start to whittle down your decision about, well, where does this person fall on the diagnostic classification. And that's how the DSM 5 is used. The DSM 5 has a number of different um, flow charts in the back where sometimes you can start to, if you're not quite sure what category the person might fall under, it helps you guide through them. One thing that has changed with the DSM 5 that was not as much an issue with the earlier versions of the DSM is there has been more and more of an attempt with the DSM 5 to have professionals be specific about the diagnosis. In there was quite a bit of research some time ago that showed that when private practitioners provided diagnoses to insurance companies for reimbursement to be paid for their service, um, a large percentage of the time they would use categories that were called not otherwise specified. There was depressive disorder not otherwise specified, anxiety disorder not otherwise specified. There were a number of different not otherwise specified categories for diagnosis. There's really been a push with the most recent version of DSM to move clinicians away from that, to have them be more specific in their diagnostic classification, to not rely so much on not otherwise specified. There are, for every diagnosis, there are still catch all categories, categories for people who do not fit the other category. But there's really been an emphasis with DSM 5 to try to move clinicians away from doing that because they often were used more often than the other categories. So um, you want to try to be as specific as possible with your diagnosis. What we will also see in this course as we move on is there are a lot of different diagnoses under each category. There also are a lot of specifiers. For instance, um, there are multiple categories of what is called major depressive disorder. Um, Major depressive disorder, first off, splits into single episode or recurrent, meaning is this the only episode this person's had of major depression, or have they had other ones? Recurrent or single episode. And then for both of those types of depression, there's mild, moderate, and medium. Mild, moderate, and severe. And then even with severe, there's different categories. Severe could be with or without psychotic symptoms. So there is a strong degree to which um, you try to be as specific as possible. And then some of the specifiers can just get ridiculously large. Substance abuse is a good category. There's multiple categories with substance abuse. Um, Mild, moderate, severe, and then the type of drug that the person is abusing. And then there are different categories for whether there is any cognitive impairment related to the drug use. So it can get very specific in a lot of different directions. So that's how the DSM-5 is used. It is a text that's essential to have. Well, it's absolutely essential to have if you're ever going to bill insurance or even going to try to get the person or even try to get reimbursed by insurance. A lot of clinicians, myself included, when we see patients, they use insurance. I just bill insurance directly, and the insurance company pays me, and then the person pays me either their copayment or deductible. But a lot of other clinicians um, don't take insurance, but they may provide to the individual they're working with what is called a super bill. A super bill is a document similar to an insurance form that the clinician would give to the patient, and the patient could try to get reimbursed from their insurance company. They could, they would send in the form and say, "Hey, I paid this for my health care, my counseling service. I would like to be reimbursed. In that case, the clinician is not involved in whether the money comes in or not. Regardless, whether you would use bill insurance directly or would help the patient try to get reimbursed from their insurance company, you would have to use the DSM 5 because the DSM 5 has codes. Every diagnosis has a code with it. And that code is what the insurance companies use. When I bill for seeing someone who has major depression, I fill out a form and I say that I'm billing for the diagnosis that I'm treating as major depressive disorder. But the insurance company doesn't really see that. They see the code. F33.1 is one of the codes for a major depressive disorder. Um, so they see the code. Now, the code may seem irrelevant, but it's an interesting thing to keep in mind about the code because the code from the DSM 5 matches up with the code in what is called the ICD 10. It's the ICD 10 now, ICD 11 is coming. ICD ICD stands for International Classification of Diagnoses. ICD, it's on its 10th edition. The ICD is the list of codes for every medical diagnoses that's out there, not just mental health, but medical. So it's a huge book, and all it has are the codes and the diagnoses that go with it. Doesn't have any criteria. The reason why that's relevant to the codes in DSM 5 is the codes in DSM 5 match up with the codes under the mental, behavioral, and emotional disorders section of the ICD 10. So if you see the ICD 10, it'll have a list of diagnoses, and those diagnosis codes match up with the codes in DSM 5. Now, the reason why that's relevant, and I won't, this is just a small side point, is because when insurance companies use codes, in reality, the only codes they're using are those ICD 10 codes. They happen to be the same codes as in the DSM 5, but the insurance company is only recognizing the ICD 10 code. That's just something interesting to keep in mind if you're ever dealing with insurance and this whole thing about psychological disorders. Why are the diagnostic categories stressed so much? And why are these codes stressed so much in the DSM 5? And one of the reasons for that is because it's the only way clinicians can communicate with insurance companies. The insurance companies don't recognize anything else as far as category, as far as diagnoses of what you're treating. Now, for many clinicians, that may actually not be a relevant point. They may only take private pay, meaning the person just pays them out of pocket. The person pays you out of pocket. These codes in the DSM 5 aren't relevant. But that's few and I mean, there aren't many psychologists who have, especially PhD and licensed psychologists, who have nothing to do with insurance at all. At the very least, they have at least some clients who are asking for this super bill so that they can go try to get reimbursed from their insurance company. But either way, you want to know how DSM 5 works because it's also how professionals communicate with each other. And when if you are talking with one professional and you are talking about major depression, you both are going to be thinking about that sort of in the context of the DSM 5 diagnosis. So it's useful, it's important to understand how the DSM-5 works. Now, there are other diagnostic manuals, diagnostic methods out there. Probably the one that falls as number 2 in the list of major, and this is way, way down on the list, but one that probably gets talked about more than the other diagnostic methods other than DSM-5 is called the Psychodynamic Diagnostic Manual. It's a different system. It talks more about personality characteristics of the individual rather than specific symptoms. So DSM-5 is sometimes criticized for being too medical, too much focused on just symptoms, and sort of seeing the criticism is that DSM-5 sort of makes the disease separate from the individual. The Psychodynamic Diagnostic Manual, it's now in the second edition, so it's called PDM2. That focuses more on individual personality characteristics and how they may match up with certain diagnoses. Now, the reason I bring that method up, you may go your entire career and never use the Psychodynamic Diagnostic Manual. It's an interesting text. It's particularly interesting in that the authors of the Psychodynamic Diagnostic Manual don't see it necessarily as competition to the DSM-5, but more as an addition, as a method that expands on what the DSM-5 does. But the reason I wanted to bring up the Psychodynamic Diagnostic Manual is it leads into the next topic that I want to talk about, which is what the different psychological theories say about stress and its relationship to psychological disorders. Our text is specifically related to stress, and stress is a major factor in all psychological disorders. And I wanted to just talk about the different psychological theories and what they say about stress and its role. And I bring up psychodynamic because psychodynamic is one of the major theories. There are 3 major psychological theories: psychodynamic, which used to be called psychoanalytic, Freud. Sigmund Freud would be the start of that. Cognitive behavioral, which grew out of behavioral theories. B.F. Skinner, that's the main author. That's sort of the foundation is B.F. Skinner and his work. And then the third is humanistic existential. That is the one author that is often related as sort of the sort of grandfather, main author who started all that is Carl Rogers and person-centered therapy. So there's psychodynamic, Freud; cognitive behavioral, Skinner; humanistic, Carl Rogers. There are other theories of psychological disorders that go in a lot of different directions. There are certainly spiritual, religious theories. There are physiological theories, medical theories of where it comes from, where they come from, environmental. So the 3 I gave you are the 3 psychological theories. They relate to some degree to the medical model. um, because a lot of the research that is summarized in our textbook talks about um, stress as a physiological factor, genetics, biochemical, environmental. So it starts there. But the theory across the board is that biochemistry puts the person in a, or genetics, let's say genetics leads the person to develop in a way that they're going to respond to stress in a certain way. But that doesn't really answer the question of how are they responding to stress. Um, and so a person with a certain genetic makeup may respond to stress in their life quicker or in a different way than somebody else might. But there are other factors that contribute to how a person responds to stress. And the psychological theories sort of try to answer the question of what factors enter into, what other factors other than genetics and biochemistry enter into how the person responds to stress. Psychodynamic. The position of psychodynamic theory is that we are all born with these drives to sort of that kind of link up with what we refer to as instincts in animals. We're all animals. Humans are animals. Dogs are animals. We're all animals at our very base, and that humans are born with these drives, a drive to uh, survive, survival instinct. It's called a survive to procreate, sexual instinct, a drive to fight for territory, um, the aggressive instinct, sometimes called the death instinct. Freud referred to it as death instinct. That is not the term used now. Um, uh, a drive to uh, protect our families and keep the species going, those sorts of things. There are a lot of other drives that are discussed, and that those drives um, are sort of lead us to be in conflict throughout our lives. You know, we get into conflict between this is what we want, but this is what society tells us we can have. And in the middle um, is sort of that part of our personality that puts them all together. Um, in psychoanalytic theory, you may have heard it as the id, superego, and ego. The id are those drives out there that sort of just what we want. We don't care about other people. We are this is what we want. And then the superego is sometimes referred to as our conscience, that part of us that says, okay, you have to respond to what the world will allow. And then in the middle is the ego that sort of tries to keep these two in some sort of stasis, in some sort of agreement. Um, and then what happens in our lives is stress can be caused when there's conflict between what we want and what we're allowed to have. And so that's where stress comes from, that we often are trying to respond to what we want to do just naturally, and yet caught in the middle of what the world, the social world, tells us what we can do. It's a way of thinking, if you were the only person on the planet, you would live your life probably completely different than when there are other people around you. And sort of that conflict of how you want to live your life and what the world tells you you can do to live your life puts us in conflict. Now, when there's conflict, it can cause stress. Individuals who are psychologically healthy, shall we say, don't have a lot of problems dealing with um, that conflict. The conflict's there, they experience stress, but they're able to manage it. The conflict doesn't spill over into a lot of psychological symptoms, or it may spill over into some psychological symptoms, but not ones that are paralyzing or impact a lot on the person's functioning. It impacts some, but not necessarily a lot. And so when psychological disorders develop, it is often because from a psychodynamic theory, there's this spillover. The way the person wants the world to be and the way the world is causes conflict for the person, and they can't handle it, and the stress spills over. So, um, now why the person has that conflict, has that difficulty, can come from a lot of different factors. It could be just totally genetic. It could be that the person was subject to a lot of trauma when they were younger. So the ability that we develop as we get older um, isn't there. The ability to manage that conflict, manage the stress, manage the difference between how we want the world to be and how it is, isn't there. Um, you can sort of see that if you look, when you think about babies. I mean, babies, newborns are entirely focused on what they want. It's not that babies are bad, it's just that's how they start off life. They're responding to what they want naturally, and they're having to learn as they get older how to temper what they want with what the world will provide. Um, but if they are exposed to a lot of stress when they're younger, that ability isn't necessarily going to develop. Um, so as the so that's sort of the concept of stress from a psychodynamic perspective. The stress comes from these internal conflicts between what we want and what the world says we can have. And stress comes about when the person doesn't develop um, the internal mechanisms to effectively manage that conflict. Cognitive behavior therapy. In cognitive behavior therapy, the theory, cognitive behavior theory, which grew out of, I'm just going to call it behavior theory because it grew out of behavior theory. The behavioral theory is that individuals are born sort of as blank slates, but we are born with these abilities to learn from our environment. So we're not born necessarily with internal conflicts already pre-wired, but and going back to the psychodynamic, what I mean by that is, from the second an infant is born, the theory goes, you can almost see it. They are sort of dealing with this conflict between what they immediately want and what they're able to get. Baby gets hungry, they can't be fed, the food doesn't appear immediately. Um, so from the second a baby is born in psychodynamic theory, they're sort of having to deal with this conflict between what they want and what the world will provide. With behavioral theory, we're not born with these internal conflicts, but we are born with abilities that allow us to learn from the environment, that allow us to learn what we need to do in order to survive and in order to progress in the world. And so, where stress comes from is when what we learn for handling the conflicts that come up, or not the conflicts, the difficulties that come up, what we learn for getting what we want from our environment isn't effective, or isn't the most effective, or is problematic. It may get us something, but it may also cause more problems. So a child um, wants to get uh, food. You know, a child, as they get to be 3 or 4 years old, wants to get food. And when they were younger, they may have learned that if they cry and scream, they will get the food. A child who is 2 months old and yells and screams to get food has learned an effective skill. A child who is 5 years old who yells and screams to get food has not developed a more effective skill. Yelling and screaming to get what you want when you're 2 months is effective, is the most effective skill. It's necessary. But a child who is 5 can use other ways of getting what they want. The biggest difference, of course, between a 2-year-old and a 2-month-old and a 5-year-old is the 5-year-old can talk. The 5-year-old can say, I would like this. The 5-year-old can move and go get the food themselves, but may have to ask for it. So the 5-year-old who then learns, well, rather than ask, I'll just go get it, has learned a skill that will get them the food, at least in some circumstances that they want, but not in an effective way, because they will get in more trouble. So stress comes about when the skills that we learn for adapting to our environment are not the most effective. And stress tends to come about when we learn those skills that tend to cause more problems than they solve. Um, and cognitive behavior therapy comes up out of the growth of behavior therapy. The way I've often been told, or the difference between the cognitive and the behavior part of cognitive behavior, is the behavior part is the external behaviors, the way we interact with the world. Cognitive is the internal mechanisms, what we are saying to ourselves. But the gist is the same. The basic concept is the same, that you are learning skills that are effective, and the skills might be how you act towards other people or towards the social environment, but also might be what you are saying to yourself and how you are talking to yourself and how you are walking yourself through problems. And so the skills that you learn can be external or they can be internal. They can be what you say and do to other people, or what you say to yourself when you're facing problems. But the general gist of all this, the general concept here, is that stress comes about when the skills you are learning to deal with situations in your environment cause more problems than they solve. And one sort of general theme that comes up in this whole concept is that what we may tend to do is learn skills for handling one situation that might work, but then not learning a different set of skills for dealing with a different type of situation that may seem a little similar but is different. We're not using different skills there. We're kind of trying to take the skills from one area and sort of applying it to others when it may not work in that situation. Context matters is one factor that's important in behavioral theory. The context matters uh, to whether the behavior is going to be the most effective or not. But the general theory is that when we have strategies for dealing with difficulties for trying to have some control over our environment that are the least effective or that cause more problems than they solve. That is the basic focus of behavior theory and the theory behind cognitive behavior theory. So that's where the stress comes from. In the humanistic slash existential theory, where stress tends to come from is when we are not fulfilling our potential. The basic theory behind humanistic theory, and I'm going to incorporate them as humanistic slash existential. I'm just going to refer to humanistic, but I'm referring to both, is that we are looking for meaning and purpose in our life, that we are all born with this, with a focus on bringing meaning and purpose into our life. And when we are falling short of that, that is where stress comes from. And when we are not seeing a purpose to our life, if we are not reaching the point that we feel like this is what we're supposed to be doing, um, then that is where stress tends to come from. So, even as children, you know, there's this desire to feel like this is what I'm supposed to be doing. Going to school, getting along with my family. Those are things I am supposed to be doing. And when we are falling short of that, that is where the stress comes from. Um, you can see the desire to find meaning and purpose even in young children. You see them in school. They're saying, um, they're in math class, and their question is, well, why do I have to know this? When am I ever going to use this? What is the purpose of this? What is the meaning of this? Um, so the theory there is that we all are looking to find purpose and meaning in what we do, and when that falls short, that is where the stress comes. We're all trying to be the most human we can be. One theory, it's not Carl Rogers, it's from a theorist named Maslow. It's called the hierarchy of needs. That we all have to, that in order to feel like we are doing what we need to do, there is this hierarchy of steps we have to take. So if we're the first one is food, sufficient food and housing, so you feel like you've got enough to survive. So the first thing you're looking for is to have those needs met. If they aren't, then that causes stress. If they are, then the stress isn't there, but then you look for the next um, uh, step. Food is the bottom step, and then the next one is housing, feeling like you're being, you have protection from the elements. Uh, and so you have to kind of meet each step to feel like your life is having purpose at that point. But then once you meet that step, then if you're not meeting the next one, then that's where the stress comes from. So every step of the way towards feeling like you are leading a purposeful life, if that step isn't being met, it causes stress. And if it has been met, but then the next one isn't being met, that causes stress. So there's this whole concept of the purpose, feeling like their life at that point has meaning, has and purpose. That's where, if that isn't happening, that's where the stress comes from. Notice how with each of these things, the general concept of stress is something isn't the way it's supposed to be. Um, and so we are all, the concept of all those is we are all trying to feel this sense of equilibrium, like everything is kind of where it's supposed to be. We're dealing with the conflicts the way we're supposed to. We're learning the skills we need to basically get through our environment. We're doing things that are purposeful and meaningful. And the idea, sort of where it comes back to the physiological part, is when that equilibrium is lost, that's where the stress comes from. So you can see there's sort of this connection between the psychological and the physical. All of these concepts, whether it's the medical talking about the biochemistry of stress, or the psychological talking about the emotional, cognitive parts of stress, uh, have this sense of the person is experiencing that things aren't where they're supposed to be. So that feeling psychologically sort of transfers over to biochemical reactions. So if the person starts to feel like they're having difficulties in their environment, they respond psychologically, but they also respond physically. And that's where the biochemical changes associated with stress come from. So there's this connection between how I feel about the environment and how my body responds to how I'm feeling about the environment. And then there could even, especially with the humanistic part, there can even be a spiritual aspect to it. Um, that everything seems off balance. The Not only I feel off balance physically, and I feel off balance in terms of how I feel emotionally and cognitively in my thinking, but it may also go into a spiritual realm that the universe feels like it's off kilter. So all those things can connect, and that's where stress comes from. This idea that things aren't the way they're supposed to be. And all of the different theories come back to that. And the physiological part comes back to that. And the spiritual part comes back to that. Okay. And then how the person responds to that lack of equilibrium uh, changes depending on the um, uh, or or changes for different individuals, and the way they respond to that lack of equilibrium um, sort of determines which of the psychological disorders come about because of that stress. And that's what we'll start to talk about as we talk about the different psychological disorders. But I think that's enough for now, and I'll look forward to seeing you on Thursday when we meet and talk about all this live.